When I think about healthcare, there's health and there's care, and care is not efficient. You take time with people, and if you engineer your system for maximum efficiency, you're not taking care of people. You're not pausing to give somebody a little extra time when they need it. On the patient side, on the radiologist side, if you're being super efficient, you're reading studies as fast as you can, and that's a recipe for burnout. That's a recipe for making errors. So I think efficiency is a little bit of a Goldilocks measure where you don't want too much, you don't want too little. You got to find just the right spot where you're not wasting time, but you're also not rushing.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogix. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Welcome back to Frame by Frame, Rethink Imaging. Today, I am so happy to be joined again by Dr. Summer Kaplan. Dr. Kaplan is an associate professor of clinical radiology at the University of Pennsylvania School of Medicine and a practicing pediatric radiologist at the Children's Hospital of Philadelphia. She has over a decade of experience in pediatric imaging with a focus on quality improvement, and she's become a key voice in advancing safer, smarter imaging practices. Dr. Kaplan previously came on an episode to talk to us about gonadal shielding in X-ray. But then we did a follow-up episode with Dr. Asanshime where we were talking about quantification of quality, which led to a conversation between myself and Dr. Kaplan about, her pillars of quality. And so before we get into the pillars, I really want to just try and talk about the benefit of imaging. And I'm curious, to you, what is the most important lens? Is there a most important lens to evaluate the benefit of imaging today?
Yeah. Thanks, Chris. It's great to be back with you. So I think that the benefit of imaging is it's tremendous. I mean, it's a huge benefit to patients, to clinicians who are trying to find answers for diseases, conditions. I think the huge growth in the use of imaging in the past 30 years, 40 years, 100 years, that speaks for itself as to how much people value being able to use medical imaging. We're visual creatures. We like to literally see what's going on. So having a picture that shows the inside of the body is just is super valuable for patients, for clinicians. So I think, the growth in just the use of imaging speaks to its benefit.
And how do you think about what is the lens that you think about that benefit? Is there a particular framework when you're thinking about it?
Yeah, so you really think about what does it add to patient care? Patients come to see the doctor, to the ER with a problem, a question, and it's the job and the goal of the care team to provide answers and then to provide help for whatever's troubling the patient. So, in diagnostic radiology, we're a huge part of providing answers. Is there pneumonia or not? Is there appendicitis or not? Is there cancer or not? And having a picture proves one way or the other in many cases whether the problem is there or not. And so the benefit to peace of mind if you can rule out a cancer, the benefit to helping patients get better if you can diagnose an appendicitis and then send them on for appropriate treatment. So really, how does imaging help the patient either put their mind at ease or get better? That's really kind of the lens that you think about in terms of how to say what the benefit of imaging is.
Right. And so can you I was far be it from me to jump in and get ahead of you and are we saying pillars of quality? Is that the terminology
Yeah,
you like to
yeah, yeah.
use?
So the pillars of quality, which I didn't make up, I wish I could take credit for it, but it was
Yeah,
it
yeah.
was developed in the early 2000s,
Mhm.
over 20 years ago now, by the Institute of Medicine, which is a large group of doctors and policymakers thinking about how to improve healthcare. Healthcare is always in crisis of some kind or another, and so at that point in time, it was really how do we, how do we migrate to a digital world? How do we, provide the best care for the most people with limited resources? Like in the United States, we have more resources than most places, but it's always limited. There's always, a limit to what you can do. So, this focus group at the Institute of Medicine came up with these 6 pillars of quality. So, quality care should be timely. It should be effective. It should be efficient. It should be safe. It should be uh, patient-centered, and it should be equitable. So those are lofty goals, and we all want that. And so the question is that we've been struggling with for the past 20 years since these pillars were sort of established and taken up by the medical community is how do we do that? How do you actually make something patient-centered? How do you I mean, making things safe and timely is often what we focus on because it's easier to measure. Measuring effectiveness is super hard. So these pillars are sort of like guiding principles that we use, but how to put them into practice is challenging.
Yeah, absolutely. I mean, I would love to just, briefly touch on all 6 pillars if that's okay. Um, so I mean, let's start off with those which are easier to measure and quantify, right? So we have, they say safety first, so safety first. I know we track dose and we do all these things. We have all of these things that we measure that theoretically point back to safety. But I'm curious specifically, like beyond dose, how should we be thinking about safety?
Yeah. So I think you're right to mention dose because that's the first thing to people's mind when you think about safety and medical imaging is the radiation. And you've had several podcasts about radiation and
Oh yeah.
so those are there in the record. Um, Really, when you're thinking about a safety system in radiology,
Hmm.
it should be ideally completely invisible to patients, right? They should never know that there's a safety system in place because they should never have events that are
Hmm.
unsafe. So this is something that a medical practice, a radiology practice wants to have running constantly to prevent any safety events. So in radiation, we do things like dose tracking. We have the equipment for CT, for X-ray, for fluoroscopy has a lot of safety mechanisms built into it. So the vendors have helped us out a lot with how to maintain low doses and prevent accidental high doses. Um, but outside of radiation, the other big safety concern in radiology is around MRI safety. And so MRI is magnetic resonance imaging. It's super powerful for seeing what's going on inside the body, especially in the brain or in the skeletal system. But it's a super powerful magnet. Like you
Oh
can see
yeah,
videos
there
on
was a
YouTube,
horror story
right? Of
recently. Yeah.
yeah, there's occasionally there's huge safety issues, right, that pop up that they're so egregious and so scary they make the news where you see, a hospital bed flying across the room, pulled into the magnet, you know, anything becomes a projectile around the magnet,
Right.
anything ferromagnetic. I mean, there was an event where someone somehow got into the scan environment with a loaded gun or
Oh,
discharged and
Jesus
shot
Christ.
them in the foot. So that should never happen. That's an example of a safety event in
Yeah.
MR, and no patient was harmed, but the person carrying the weapon was harmed. So around MR, it's a completely different safety environment. You know, eh, in part because you're worrying about real time right now problems, like is there a projectile that could fly into the magnet and harm a patient? Whereas in radiation, it's all long term. Like, could this scan now lead to a higher risk of cancer 15 years from now. Like it's very removed. But MR, it's like right now could there be harm to a patient? And it's the nature of radiology. There's so many people coming in and out of our imaging environment. It's patients, it's hospital staff, it's radiology staff. And so making sure that everybody knows how to be safe in the MR environment it's a big task that we struggle with. So there's MR safety. And then I think the other safety issue is around just making sure that patient information is kept confidential, making sure that, you're doing the right body part. You don't want to scan someone and find out, oh, that was actually the left leg we meant to scan. So scanning the wrong body part is a safety issue as well.
It's funny. It makes me think of this is a non sequitur, but there's a joke in the TV show 30 Rock where there's a kidney transplant happening and the doctor writes it wrong on the sheet. He's like, oh, no, I'm not giving him the kidney. He's giving me the kidney. And he pulls out the form and he goes, no, I don't need to change it. I'll just remember it's the opposite. And he looks at the form and he goes, opposite. And later on the episode, they're like, no, he's giving me the kidney. And he's like, that's not what this form says. It's
yeah. Fantastic show.
Yeah, so good.
Dr. Spachemin, right?
Yes, exactly. Yes. One of like the best doctor characters in
absolutely.
My opinion.
Yeah, so don't do that. Don't do that. That's an example of unsafe practice.
Yes, not being a Dr. Spachemin.
Yeah.
And I know we kind of glossed over dose, but I want to touch a little bit on we talk about cancer risk as this, long-term statistical hypothetical, however you want to phrase it, whoever you are, whatever your views are on it are. How do you weigh the safety trade-offs between over-imaging, under-imaging, especially in like a pediatric?
Yeah, that's like a great question. And some of your other speakers probably have gone into this a little bit, but there's really two different types of radiation risk. There's the long-term cancer risk, which is what people worry about. That's what makes the news. But there's also, a more immediate risk. If an extremely high dose is delivered, you can get radiation burns, you can get cataracts in the eye. So there are some things that are a little bit more immediate with radiation. And in diagnostic imaging, we are like 100 times, 1,000 times below the levels that cause that kind of harm. So when you think about how to balance the risk and the benefit to each individual patient, the risk of a single scan for diagnostic purposes, you have a headache, like do you have a brain tumor, a head CT for that purpose poses almost negligible risk to an individual person. I think we start to worry when a person gets many scans. If you are getting a head CT every day for 2 months, your risk is going to increase. But then you balance that against, well, maybe you're in the ICU with a traumatic brain injury and those scans are keeping you alive because they're checking to make sure that your intracranial pressure and anatomy is normal or is as normal as it can be. So I think that for each individual patient, it's kind of a different calculus of how the benefit outweighs the risks.
I'm trying to decide if I wanted to ask a question about like measuring that, but I mean it feels
I think
incredibly
Dr.
nuanced.
Sameh, who you had on earlier, gave such a great summary of that, such a great like analogy of measuring radiation, and it really doesn't give you a sense of the value of the scan, right? Like he spoke about measuring calories doesn't tell you how good your food is.
Right. Yeah.
And so
exactly.
measuring radiation doesn't tell you how valuable the scan is. Measuring radiation is tricky because you can measure how much the machine is producing, but how much of that the patient receives, like they don't receive all of the radiation, right? There's some that falls around them. So they receive a fraction of what the machine produces. And then, only a fraction of that radiation is going to cause the kind of cellular, reaction that could predispose to cancer. So of the radiation that reaches the body, only a fraction of that may pose a cancer risk. And then the other like wild card is each individual person has different genetics, different risks for cancer. And so in one person, you get, say 5 of these cellular reactions and they can't repair them and they go on to develop cancer. And somebody else, their body eliminates those cells and they don't develop cancer. So it depends on individual genetics. It depends on the body part being irradiated, right? So some body parts are more sensitive. Typically, those with higher cell turnover, like your gut lining, is fairly sensitive because the gut lining is always being replaced. There's always new cells coming in, and that's similar to why we worry in children because children are growing, so they're always making new cells, and their cells and their genetic replication systems are just a lot more active. And when you have genetic replication, that's where the radiation can potentially cause harm. So that's why we worry more in children. And also because children, have a longer lifetime over which to develop a cancer. If you give radiation to an 85-year-old, there's a good chance they might die of something else before they would develop a radiation-related cancer. But if you give that same radiation to a 5-year-old, theoretically they have 80 more years of which to develop a cancer.
Right. Which, I do not believe that is what you mean by timeliness, but that does. But I feel like that feels like a really good moment to transition to the next pillar, where we talk about timeliness.
So for patients, when you talk about timeliness, you want to arrive at your appointment and be seen at the time of your appointment. You don't want to be waiting around for an hour when you were supposed to be seen, an hour ago. And then you also want your results to be timely, right? So you get your mammogram, you want to get the results as soon as possible. You don't want to wait 3 weeks for your results. So from the patient perspective, waiting time and then time to, the answer, the report is those are often the 2 key measures. I will say for some longer exams like MRI, where somebody's maybe laying in the scanner for an hour and a half for a complicated exam, like that can also be a timeliness issue. Like making the scans as short as possible benefits patients. It also benefits other patients because the shorter the scans, the more patients we can see. So when you're, long exams can lead to longer delays in care for everyone. And for ordering clinicians, it's similar. I mean, the ordering clinicians are not as concerned maybe about the wait time. They don't experience that, but they want results in a timely way. And for radiologists, we like to get through our work. So if we have, a long list of things on the, that we have to read, we try to be as timely as we can. And so, making it possible for us to get the exams read in the time, like often there's a goal of a certain turnaround time for reads. Being able to get our exams done in that time is what we're interested in. And making this all work requires systems to support it, right? You have to have staffing, you have to have check-ins in the clinics, you have to have enough radiologists to get through the work. So it's a whole systems way of thinking about how to get people their imaging is in a timely way.
Right. Which, it's especially nowadays, right, where everybody is probably pretty understaffed to some degree, big exam volumes are going up, which has benefit to it, but also
it's a very popular product we have.
Yes.
Right. Yeah, it's funny. I go to these meetings, where we try to figure out like how do we deal with this growing demand for our services, and we try to figure out ways to decrease the demand for our services, which is wild because like who wants to decrease the market, right? But we just don't have. We're limited. We can't scan everybody all the time, even though that might ultimately help. But
yeah, I think I saw something published. They estimated scans were going up like 6 to 8% a year, which I feel like that might even be a little low. And it's not like y'all are getting 6 to 8% more staff every year.
Right, for sure, for sure. Yeah, 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 it's difficult. I mean, our digital systems are so efficient, right? We're very efficient at getting scans done, so, it's easier and easier to order scans and to perform scans, and then, we try to keep up with the demand, with the reads.
Yeah. I mean, like, unless you have any other touch points on timeliness, honestly, I'd love to kind of like gloss over it a little bit. Because like while we're talking about that, we're talking about patient volumes, we're talking about, capacity in some sort of context. The next pillar that I want to talk about, patient-centeredness, I feel like really ties into the narrative at this point, right? So like what does a patient-centered approach to imaging even look like?
Yeah, so that's a good that's I would say one of the most important pillars, and other pillars all lead into that, right? So in order to center on the patient experience, you want them to not wait around. You want them to, not have a lot of distress when they're in the scanner. In pediatrics, especially working with kids, so that they're not afraid of the scans. Is something that we do that would add into patient-centered care. Having child life services, um, explaining to people what to expect for the scan. So it's really like the care part of healthcare. How do you make sure that patients and families feel welcome, feel like they're in good hands? And so that's ultimately what we are trying to do. But how to measure that and how to ensure that we are providing patient-centered care is it's one of the more challenging things to measure. And we try to measure it with, surveys. People, if you've been to the hospital or been to the doctor's office, you often get an email survey. How was your experience? And who has time to read emails and fill out surveys? People who are angry. People who are angry. And so you get a lot of, you don't get necessarily the most realistic feedback. You get kind of biased feedback from people who are
You get
who are
like worst
upset.
case scenario feedback, I
Yeah,
feel
yeah,
like.
which is I mean, it's good to know. It's good to
Yeah.
know, but it's not a really good representative measure of how we're doing. So that's, it's a struggle, and it is the most important thing that we do. Some hospitals will have, and some practices will have, like, patient and family care advisories. So sometimes we do things like that to try to get feedback and, make sure that our imaging practices are serving that need for patients.
I mean, I'm curious, like, obviously, patients. I feel like it's so often on this show and just in general in healthcare, talking about patients as a monolith, right? It's like obviously they are not. Uh, they are humans, which we're a diverse little group. But I'm curious, like, with the patients that you interact with, like, do you feel overall like they are like internalizing and like appreciating the value of being imaged to some degree?
Yeah, that's a good question. So I think yes and no, because patients are diverse. So, like,
Tell me
patients
about it. Yeah,
patients
in with the
yeah,
understanding that non-monolithic patients, right?
yeah, yeah, and I can give you a couple of examples on either side. A lot of times patients arrive in the ER asking for imaging, like, they're there because their head hurts and they want a CT. And so for patients who come, and I've actually been that person, like, my son had headaches when he was 7, and I'm sure it was from just looking at his iPad, 6 inches from his face all day. But, you worry. So I
Yeah, of
call
course.
his doctor, and, she listens to the story, and she's like, "Yeah, I don't this doesn't really warrant a head CT, but just, do this, do that." And even as a radiologist, knowing that she's following appropriate clinical
Hmm.
guidelines, I was like, "But I want a CT. Like, I wanna know what's going on. I wanna see what's what's in his
Right.
head." So it's like even me as a radiologist I have that desire to see what's going on, to see imaging, and so I think that's true for, many, many patients and families who come in with a problem. They wanna see the body part, they wanna see what's going on. And so for them, like, the benefit to getting imaging is inherent. But then you also have, in pediatrics, especially with kids who are too young to understand what's going on, or kids who are developmentally delayed and, you really can't explain the situation. It can be scary, especially things like MRI where you're in a dark, you know,
I had
hole,
an MRI
a dark
last
and
year. It
noisy
was
hole.
yeah, it was horrifying.
Yeah, yeah, and it's hard not to be claustrophobic in there,
Yeah.
or they come to fluoroscopy, and we're asking them to swallow some disgusting liquid so we can, like, look at their esophagus and their stomach,
Hmm.
and, like, you can't explain it, so they don't wanna do it. So that can be a challenging, part of trying to provide patient-centered care, like, if the patient needs the exam in order to, rule out a perforation or a tumor or something, but they don't want it, um, how do you work around that? That's something that can be challenging in patient-centered care.
Well, right, and it feels like to some degree, like especially with peds, or you said like some uh, children who might be developing a bit more slowly. Like you have and on top of that, hearing you talk about being a mother with a child and wanting to get them imaged, it's like it's not just patient-centered care, right? To some degree, it's family-centered care. So I mean, and how do you walk that balance involving, parents of patients in these imaging decisions, especially if there's like diagnostic uncertainty?
Yeah, I mean, I think the way I try to approach it is to understand exactly what the concern is, and, for parents, often it's radiation is the concern, and so I try to explain how low the risk actually is, because there's so much scary news about kind of outlying, unusual, like, 1 in a million cases, that the vast majority of imaging is so safe, and I don't know if this is effective, but I tell people sometimes that, the imaging is like one of the safest parts of your day today. Like, your drive to the hospital
Right.
was 100 times more risky than this
Uh-huh.
exam you're about to have. Maybe it makes them feel bad, feel scared about leaving the hospital, but,
That's funny.
it's
That's
true
what I do on airplanes.
numerically.
The whole time, I like, as a kid I loved to fly, but as an adult I have developed some intense fear of flying, and I spend the whole time in the airplane being like, the drive to the airport was more dangerous. The drive to the airport was more dangerous. Like, statistically, I am much safer here.
Trying to understand what the concern is, and sometimes if a kid is just so agitated and so much distress, you just can't do the scan. You don't wanna tie somebody down and force them to get a scan, that's not okay. So, do you reschedule? Do you bring in child life services? Do you need sedation? Like, you kind of work through the problem. So sometimes, patient-centered care means you can't do the exam that's requested at that time. You have to work around and maybe try a different time.
Moving on to equity, I think, especially in 2025, this is a very pervasive uh, topic to touch on, because I mean, we know inequities exist in imaging across the country, right? But like, what are we not really talking about when it comes to equity in terms of quality?
Yeah. So equity, in general, just means that the same solution is not going to work for everyone. We're all widely variable. Um, and so with systems approach to providing equitable care in radiology, you just want to make sure that there aren't certain populations of patients that are being treated differently. Um, Whether that's, having access to care, if you have 18 imaging centers and one of them has, lower availability of appointment times or older imaging that breaks, like, the patients in that who go to that imaging center are not receiving the same care as other patients. So,
Right. And if they're on older equipment that is breaking more, like, aren't they quite probably getting higher doses as well if some of this older equipment is what's taking the images?
right. So sometimes those inequities can be geographically based. We worry about kind of your historical race-based and socioeconomic, poorer people getting worse care. You can also conversely see affluent people getting excess care. So there's that aspect that also happens. Um, and like so many of these pillars of quality, it's hard to measure. It's really hard to measure because people are so varied and, we collect a lot of data in the medical system. It's just there's so much data. Who has time to look at it all? And so in research institutions, there are often staff to look at it. And so there are people whose academic focus is studying things like that. Like, are we systematically treating certain populations different than others unintentionally, usually? I mean, nobody's intending to disenfranchise people, but it just happens, if you're not alert to it, it can just happen without your noticing. So you have to pay attention and really look for the information.
Yeah. I mean, have you seen any like efforts or attempts either by you or by others, like in an attempt to measure and track equity, like within specific departments?
Yeah, yeah. So in radiology, I think it's a bit challenging for us because we get requests from clinicians. So we aren't the decision makers in who gets imaging. We do the imaging. But when it comes to like utilization of imaging, there are people who look at equities and inequities in utilization of imaging. And there are clinical guidelines around, use of head CT for headaches, right? And so there was a paper, and I hope I'm not going to misquote this, but there was a paper in the last few years looking at use of head CT in children with headaches in the ER, and like, is there a difference in terms of race, how often CTs are done? And it found that white patients are getting CTs more often than Black patients or Latino patients. Um, and so that's identifying an inequity. And then the next question is, are the patients of color being underimaged, or the patients who are white being overimaged? So that's a lot of research is like that. You ask a question and then it just raises, 18 more questions. But identifying race-based differences in how you're providing care is the first step, because if you don't look, you don't know, and then you can't address it.
Yeah. And like, I mean, and how do we move from not just identifying inequity, but like how do we start building systems that can address closing that gap?
Yeah, I think, well, there are clinical practice guidelines that should be used, and that's always challenging too because everybody's different. Maybe you're someone who doesn't fit the guidelines, but ensuring that there's kind of common practice guidelines that are used. It's interesting in radiology, we don't know people's race, right? I see an X-ray, a chest X-ray, like I have no idea if you're Black or white, or if you're an immigrant or not. Like, we just look at the picture. So in some ways, radiology is really blind to a lot of those things. Like, as a radiologist doing the scan, I mean, the patients may have a different experience, getting scanned, like the experience of coming to the hospital and how they're treated at the front desk, or there's so many steps that the patients go through that I, as a radiologist, don't really see or influence at all. But in terms of reading images, it's very blind to all those all those factors. Yeah, so I think when you talk about equities in radiology specifically, it's a lot of it's the patient experience that, it's not really the medical part of the practice, but it's everything around that.
Is there such a thing as too much efficiency when it comes to imaging?
Yeah, I think so because, when I think about healthcare, right, there's health and there's care, and care is not efficient, right? You take time with people, and if you engineer your system for maximum efficiency, you're not taking care of people. You're not, pausing to give somebody a little extra time when they need it. On the patient side, on the radiologist side, if you're being super efficient, you're reading studies as fast as you can, and that's a recipe for burnout. That's a recipe for making errors. So I think efficiency is a little bit of a Goldilocks, measure where you don't want too much, you don't want too little. You got to find just the right spot where you're not wasting time, but you're also not rushing.
Right. And it's like, yeah, we need to be more efficient, but efficient at what? There's all these different pieces, right? Like efficient at getting the scan done, efficient at reaching a diagnosis, efficient at serving the patient. Like, yeah, the balance feels tenuous at best.
Yeah, and I think the best way to think about it is just not, not having a lot of waste in your system. Like, so patients shouldn't have to fill out the same paperwork twice. They should fill it out once, and then we have the information. Um, I shouldn't be reading studies and bouncing back and forth and being distracted in a way that makes it hard for me to focus on my work.
Right. And you touched on like if like efficiency being focused on to the point where it maybe starts to impact care negatively. Like, have you ever come across a system that like just started getting way too efficient that they just started missing the point, right?
Yeah. I mean, I think that's I mean, outside of radiology, I think the most common patient complaint, right, is the doctors don't take time with them. The doctor is typing on their computer, barely making eye contact. It's a 10-minute visit, and how can you get care in that time? In radiology, yeah, I think the volume of studies is an example of how we're so efficient at taking an order, making an image, and then, you know, we have all these, we the radiologists become the bottleneck in, being able to read the studies, in a timely way. And I think, for the as a radiologist reading studies, you can be, if your system is designed for efficiency to get as much work as possible in the shortest amount of time, that's not, that's not a good way to work long term. It's good for the bottom line, but it's not good for the radiologist. It's not good for the patients because you don't take time to look at the study and ask some questions and read about the patient.
Yeah. I mean, and we I want to respect your time today. So finally touching on effectiveness, right? How do we define, or how do you define whether an imaging exam was effective, right? Is it just diagnostic accuracy? Like what?
Yeah, I think that's so aside from patient-centeredness, I think, effectiveness is the most important safety, okay, they're all important, but effectiveness is really the core of what we do, and it's so hard to measure how effective you're being, and so I think, yeah, an accurate diagnosis is ultimately the most effective thing, but it's often true that the exam may not give you a single diagnosis. You may have, you see a thing and then you have a range of like 3 different things it could be. You need more information. So it's still effective though. I think if you have an imaging exam that helps direct the patient and the clinical team down a pathway, you rule out some things, you leave some other doors open. That's effective when you're changing care based on the exam. It's not effective if, an exam is done for, I don't know, for urinary tract infection, and it's a known urinary tract infection, and we do an exam to check for urinary tract infection. Like, we knew that already. Maybe the question is deeper, like how far up does it go? Is there any complication? But if the exam is just to look for something that's already known, or if the exam is ordered and it really can't assess the question, um, I'm trying to think of an example of that. Yeah, so if the exam is ordered and it, in pediatrics, we do, ultrasound to look for appendicitis, to spare radiation. But, pediatrics go from age 0 to 18-ish, and so some of our older adolescent patients are adult size. And they don't use ultrasound in adults because the larger the body, the harder it is to use ultrasound to see deep into the tissue. So if we have a larger adolescent patient and we use ultrasound for appendicitis evaluation, it's not effective because it's not the right tool. Like for a patient who's thicker, you need a CT, you need an MRI or something. So that's an example of how you could, you know, use imaging in a way that's not effective because you're not using the right imaging for the question.
Right. And do you think there's a good way to track or reflect imaging value like at a system level?
So the value, you know, I guess the sort of economics answers that value is quality divided by cost. And so, if your quality is higher, your value is higher. If your cost is lower, your value is higher. But that's such a simple equation, and it doesn't really reflect the complexity of how do you get to quality? How do you develop these 6 pillars so that you're doing quality care? And even cost is complicated. Cost to who? Cost to the patient, cost to the hospital, cost to the insurers. So that whole equation is too simple to define value in healthcare. Um, I think the first step is just developing measures. So radiation is something we can measure. We measure it. Timeliness, turnaround times are things we can measure. So we measure them, and it's a start. But there's so much more that's even more important to try to quantify in some way. And so that's the challenge.
Yeah, I mean, is there a measure of effectiveness that you wish more health systems actually tracked?
Yeah. So we have a lot of clinical guidelines. Um, it's even more true in adults, but even in pediatrics, we have guidelines for practice. And I don't think there's any system that really measures how 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 much they're followed. So I've been on guidelines committees, and it's frustrating to we spend so much time and effort and resources developing guidelines, and then who uses them? You know, maybe people use them, but they're often not used. And so making it possible for those to be part of the clinical workflow, I think you can't add more checks and more, tasks to the clinical workflow because we're talking about hardships and challenges in radiology, but on the clinical side, there's even more minutia that creeps in every single day. So I think, you know, building a system that can measure effectiveness in a way that doesn't add to the clinical burden is like the holy grail or whatever. It's like what we try to get to.
Right, and do you think like the radiologists are being asked to like prove their effectiveness more so today than in the past,
I I
or not
don't I
really?
don't think so. I think just
Okay.
the people rely on imaging so much, and I think that,
Yeah.
that is like you asked earlier about the value of imaging and the benefit. I think that's also speaks to the effectiveness of imaging, that it's the demand only goes up, and if it was not effective, that wouldn't happen. So I think our volumes we're a victim of our own success, where our there's a benefit, there's value, it's effective, and so people use it.
Yeah. I mean, and so we are starting to approach the end of our time today, but I'm just curious. You have hinted, maybe not so indirectly, at like pillars that resonate more with you, pillars that are maybe more
Yeah,
nuanced or
yeah.
more complicated to talk
I have
about.
my
I'm
favorites. Yeah.
Yeah, of course. But what I'm curious, like personal favorites aside, what do you think of the 6 pillars are the ones that radiology struggles the most with?
I would say effectiveness, because that speaks to the whole system of care, not just our work, but like how do orders come in to us. Um, and that's what's the most challenging, because we have no control over who decides to order what when. We have no control often over whether the study is the correct one. Decades and decades and decades ago, there were a lot more conversations between radiologists and the doctors ordering the studies, but that's just not how it is anymore. And so effectiveness, relies on input so that we can give effective output. And that's challenging because our systems are so big and kind of impersonal at this point.
Yeah. And I mean, l- last question. I mean, last question to you is to ask about a question for you. Like, what question do you wish folks would be asking more when they're talking about imaging quality?
Yeah. So I think for patients and families, when an imaging study is recommended, asking how will this help? How will this benefit? What are the risks? Uh, you know, and for me as a radiologist, when I do talk to clinicians about a study that doesn't seem like it's the right one, I always want to get them to tell me what they're concerned about. Like, so don't tell me pain, tell me diagnosis. Like, are you concerned for appendicitis or, a tumor or a torsion? Like, what is your specific concern? Because sometimes they don't have time to stop and think. It's just like pain. Let's image where it hurts. But to take that a little bit of extra time and think about what could be causing it, that helps us be more effective and get the right study for the patients and for patients, to advocate, patients and families to advocate for themselves, whether the study is going to help, in what ways is the study going to help.
Yeah. So before I let you go today, do you have any final thoughts on the 6 pillars that you want to leave our listeners with?
Yeah, no, I think I appreciate the opportunity to talk to you about this and to talk to your audience about it because, we all want to provide and receive good healthcare. It's scary to be a patient, and I hope it's helpful to know that hospitals and healthcare centers are thinking about these things. It's and how I guess the point of our discussion today, to me, in part, is to help people understand how hard it is to actually measure these things. These are all principles that we believe in and we want to see put into practice, but how to measure them and be sure they're happening is challenging, and we're working on it, but it's challenging.
Yeah. Well, Dr. Kaplan, thank you so much for joining us again today on Frame by Frame Rethink Imaging. It is truly always such a delight to have you here.
Thanks, Chris. It was great talking with you.
Frame by Frame Rethink Imaging is brought to you by Imalogix. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogix is rethinking imaging in healthcare, visit Imalogix.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogix, thanks for tuning in.